This case emphasizes assessment and treatment of a witnessed cardiac arrest patient in VF or pulseless VT, who is unresponsive to initial countershocks. Multiple interventions are often necessary in this situation. Skills needed for successful performance in this scenario include CPR for continued arrest, assessment of a full cardiac arrest, routine reassessment of a cardiac arrest patient, recognition of a VF and/or pulseless VT, repeated defibrillation with a standard manual defibrillator for VF and/or pulseless VT, attaching ECG monitor leads, directing the resuscitation team to provide multiple interventions, endotracheal tubes as a drug delivery route, alternative airway maintenance methods when endotracheal intubation is difficult, IV access sites and drug delivery for cardiac arrest patients, and pharmacologic administration of agents for a cardiac arrest patient. We will now see a critical care situation involving refractory ventricular fibrillation.
Oh, he's in VFib. Mr. Franklin, Mr. Franklin. He has no pulse, no respirations.
Code Blue Room 712.
Patient's in VFib.
Once ventricular fibrillation has been identified on the monitor, the first priority is to defibrillate the patient. A series of 3 shocks is given with no CPR or pulse checks between shocks unless the rhythm changes.
Charge to 200.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
Still in VFib.
Charge to 300.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
VFib.
Charge to 360.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
Still in VFib.
Still no pulse.
If the first 3 shocks fail to convert VF, the clinician should confirm the rhythm and check for a pulse. If no pulse is present, CPR should be resumed. The patient should be hyperventilated in preparation for endotracheal intubation and IV access obtained.
Let's start CPR. He's still in VF. We've shocked him 3 times.
I'll start CPR.
Okay, hyperventilate while I prepare to intubate.
And 4 and 5. 1 and 2 and 3 and 4.
Okay, stop ventilations. Okay, suction ready.
It's all set up.
4 and 5.
Okay, cricoid
1
pressure.
And 2 and 3 and 4 and 5. 1 and 2.
Stop CPR.
3 and
Tubes in. Let's give him a couple breaths. Check for breath sounds.
absent. Okay. Okay.
Continue ventilation. Let's restart CPR. And give him 1 milligram of epinephrine.
Epinephrine is the first drug to use for any pulseless rhythm. All medications should be circulated with CPR and must be followed by defibrillation within 30 to 60 seconds. Up to 3 stacked shocks may be given.
He's still in VFib.
Okay, let's shock him again with 360.
Charged.
I'm clear, you're clear, everybody's clear. Shocking now.
Okay, no pulse, resume compressions. What's the patient's history?
Came in last night with chest pain. He has a permanent pacer, but no other cardiac history. He's currently on IV nitro and IV heparin.
Since epinephrine with defibrillation has failed to convert the patient's VF, the clinician moves on to other antiarrhythmic medications. The first of these is lidocaine. The patient's history and current medications do not provide any contraindications for lidocaine.
He's still in VFib. Let's go ahead and give him 1.5 milligrams per kilo of lidocaine.
Lidocaine's in.
Okay. Let's go ahead and shock him again with 360.
Charge to 360.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
I don't have a pulse. He's still in VFib. Let's go ahead and start CPR. It's been 3 minutes. Go ahead and give him 1 more milligram of epinephrine.
Epi's in.
Still have VFib. Let's go ahead and shock him again with 360.
Charge to 360.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
The first bolus of lidocaine with defibrillation failed to convert the patient's VF. In some cases, it is acceptable to give an additional bolus of lidocaine to a total of 3 milligrams per kilogram. For this particular patient, however, the clinician chooses to proceed to administration of another drug, beryllium.
There's no pulse. He's still in VFib. Let's go ahead and start CPR. Let's give him 5 milligrams per kilo of beryllium.
I think he may be having an infarct. Is his first set of cardiac enzymes back?
The first set's back. His total's high, but his ISOs aren't available yet.
Bertilium's in.
Still have VFib. Let's go ahead and shock him again with 360.
Charge to 360.
Charged.
1, I'm clear. 2, you're clear. 3, everybody's clear. Shocking now.
Okay, I have a pulse.
The patient converted to a normal sinus rhythm following the last shock. Assessment of the patient, including a check of respirations, pulse, and blood pressure, should be performed immediately following resolution of the VF and/or VT.
Rate's about 80.
Let's go ahead and check a blood pressure. Let's go ahead and get a beryllium drip, 2 milligrams per minute.
The patient's still not breathing on his own. Let's call and get a ventilator. As soon as we get a chance, let's get a 12-lead too.
Pressure's 80/40.
Once VF and/or VT has resolved, clinicians should begin an IV infusion of the antiarrhythmic that appeared to aid in the restoration of a pulse. Supporting the patient's ventilation in the immediate post-resuscitation period is also critical. Some common errors in a situation like this include not performing CPR when required, not ventilating the non-breathing patient with an effective adjunct, not progressing to endotracheal intubation, defibrillation errors, including failure to shock after each drug, and errors in drug selection or dosage.